Hello. Thank you for asking me to speak today to you. I hope that you find this talk interesting. I'm going to start with a piece of music. Perhaps you might ask why. Reflect on it as they play. Now, patient safety has been here a long time, as you can see, from the early ages, through all the different ages you can imagine. There's been patient safety. And in our age, it really started at the age of quality of control, and in 2000 to Earth's Human, and then now the World Patient Safety Action Plan. And we all now have patient safety on our agenda. But what do we need to do to be safer? To Earth's Human is the point where it all started in the United States, and often people would say, well, that's what's the action where it said over 100,000 Americans died every year because of poor safety events. Well, imagine what happens worldwide. And we've got to say, what is in this black box, the black box of patient safety? So in this talk, I'm going to ask 3 questions. Why is it important? What are the challenges? And how do we become safer? What can we do? And what can you do to be safer? The first step is the why. Why is it important? And there are 2 aspects here. Firstly, the extrinsic, and then the intrinsic reasons. Of course, the extrinsic reasons are the people and their families who are harmed, what we call the first victims. And as you can see, there are many of them, and you all will know or have experienced of a first victim and their family. And it's not something you want to experience. And looking on a worldwide basis, in 2018, these reports said 8 million deaths came from unsafe or poor quality care in lower middle-income countries. And of course, that's an underestimation. And when they looked at this again in 2019, this comes from Pabliotti. She says 1 in 20 patients. But Bates repeated the Harvard study that was done in the 1990s. And in this random sample, almost a quarter of the patients in these Massachusetts hospitals are getting unsafe care. So it is a problem. And then, of course, we have the WHO handbook guidelines coming out for the World Patient Safety Day that they've had over the future, and this is the year of patient safety. So these are the reasons why we need to do it, the moral imperative of being safe. This year, the World Patient Safety Goals are aimed at children and neonates, and I was fortunate to work on these goals. And these are something that you can do, a call for action, engaging children, parents and their families, enhancing medication safety, improving diagnostic safety, preventing healthcare-associated infections, and looking after neonates who are at high risk. So those are the extrinsic goals. But now there are also the intrinsic. It is a personal issue. All of us in healthcare may have experienced an adverse event or a near miss. We all have a story. My story started at this hospital, at the Red Cross War Memorial Children's Hospital, when I was a young doctor, and another doctor who I was supervising inadvertently asked for 5 mils soda bic, which is this, and he got 5 mils potassium chloride. He gave it to the baby, and the baby died. And I had to tell the parents we killed the baby. So we were second victims, and I didn't know this was my first patient safety event, because then it was called medical misadventure. It was a human factors problem, and we didn't know about human factors in those days. We weren't taught about them. So patient safety is very personal, and We are all second victims at some point in our career. So I'd like us to think about the reasons, the why. The why it is the extrinsic, those are the people who we care for, and the intrinsic, and the moral imperative that we have to provide safe care. And everyone has their why. So if you want to change people's actions, you have to understand their why. This is important. The second step is, what are the challenges of patient safety? And there are many. And I'm going to go through a few. These are not exhaustive. I just want to give you some that you can start thinking about as you plan your patient safety days. The first one are the 4 Ds. This was aimed at children but applies to everyone. People go through different developmental stages and physiological stages. At the beginning of life, they grow. At the end of life, they deteriorate. They're dependent in the early days, dependent in the last days. They have differential epidemiologies which change over every age. And demographics, the social determinants of health, impact the 2 extremes of life. And along with these go patient safety challenges. Then there's the challenge of deterioration in the sick person, the slippery slope. This comes from New South Wales, and this shows that if you don't intervene early enough, they fall off this cliff, the slippery slope, and you need to really act very quickly. And this is an important concept when you're trying to prevent the death from deterioration. Then, of course, we live in the age of climate change, and climate change affects the poor the most and has patient safety risks and health risks, which we do not recognize. And therefore, we need to think, how can climate change affect the safety of people? It may be, if you're in a lower middle income country, it may impact on having an event like flooding, and in the healthcare center cannot get the supplies. So your supply chain is messed up. So it can affect you in many, many different ways. So climate change is the latest patient safety event. And then there's challenges in inequity. Marginalized groups have a higher risk of safety. Diagnostic safety becomes an issue. And we're ready now to think about the social determinants of health. These are very important. The poor get really a bad deal when it comes to patient safety. Because of cultural competence, ethnic minorities have problems. We have structural isms and beliefs, which leads to implicit bias. And all of this makes a difference. And then finally, there is chronic care, because these change. Now, over the past decades, we've improved our care, so people are living longer. And because people live longer, it means that they get more comorbidities, and we are not used to managing them altogether. We work with them in silos, and that increases the safety risk. And there's one other area that I need to mention here is diagnostic safety, because diagnostic safety is the new kid on the block. That means it wasn't recognized as so important earlier on, but now it is going to be a major area in patient safety. In the future, we have the problem of artificial intelligence. It's going to be a tool that we can use, but can have patient safety challenges. Digital and telehealth came in during COVID particularly, but the patient safety impact is only now being recognized. And finally, on this section of the talk, we have to look at how do we get smart people? That's right, smart people, doctors and nurses. How do we get them to implement what we know what should happen? The right thing, the first time, every time. And that perhaps is the most difficult part of all that I've said so far. So now we're going to concentrate on the how we can be safer. And how we can be safer is so essential. We know why, the intrinsic and the extrinsic. And of course, I believe that the intrinsic may be more important. We know the challenges that we have to overcome, and that can be overcome. We have solutions for most of them. But now how do we implement and make changes? So you remember the orchestra that I showed you. Here they are again. It's a chamber music, not an orchestra, but a chamber ensemble. There are 5 players. There really used to be 4 players because it's a quartet, but this is a quintet, so there's a fifth one, the middle cello, and each of them has a role. And here are their roles. The first violin is culture, leadership for safety. The second violin is to educate for safety. The viola is ensuring the well-being of the staff for safety. The first cello is measuring and design for safety, and that's what we have had for quite a while. But now we also know that the fifth cello is co-produced for safety. So for the rest of the talk, I'm going to go through each of these to show that in order to have good outcomes, all of these players need to play in harmony with each other. Because imagine if one of them plays out of tune, the whole piece doesn't work. If one decides to play faster than the other and not listen to the cues that they are given, then the piece will not work. If they do not relate to the audience, then they'll not have a good show. So just like that, healthcare must play like a chamber music piece. They must play like the quintet that I'm going to show you now. So let's look at the first violin, culture and leadership. We must connect with the why to get the smart people to do the right thing every time. Why do they come to work? What's more important for them? What is their vision? Why do they want to do medicine? Why are they in healthcare? And this is all about culture. This culture that eats strategy for breakfast. So culture is the key in patient safety. And if we don't have a good culture, anything else we do is a waste of time. I like this saying from a friend of mine, Pat O'Connor, what you permit, you promote. So if we permit bad behavior, we promote in bad behavior. Because what actually is safety? The why. It's what we think and believe, what we value, what we do, and what we produce, the outcomes. So this is what culture is about. And if we have thoughts that it's not important to wash our hands, for example, then we're going to get infections. And this requires values. And if you're leading for safety, you have to have values. And here are some of the values I believe are important: of courage, vision, respect, kindness, and transparency. These values underpin our safety culture. And if you don't have values that are good values for safety, then you're going to have harm. And James Reason came up with a number of pillars of patient safety. It must be just and accountable. It must be informed so you know what's going on. It must be flexible to change with context. It must be reporting so you know when things don't work well, but more importantly when you know that things work well. And it must have leadership. And leadership is so important for patient safety. And this requires a just culture. That is, from the board to the front line, and from the front line to the board, with values that I've mentioned, mainly trust and respect. It must be reliable. That means we say what we're going to do and we do it, and we use human factors and other theories. There must be continual improvement with the theories and methodologies we use in improvement science. The just culture, as I've mentioned, must have accountability and good behavior. This requires teamwork, and we need to build on teams and make up teams. And finally, you require psychological safety. And psychological safety means that everyone must feel free to speak up. Just reflect, what is your safety culture? Is it pathological? Reactive? You do a lot when something happens. You have systems in place called calculative. You count a lot, report a lot. You're proactive. You anticipate and prevent. or safety is your business. It's generative. So culture is the number one thing that you have to look at. Within this culture, you go to the second violin, who supports the first violin through Educate for Safety. And this means we have to have a learning system for safety. And here I've adapted this from Glenn Elwyn's work on a learning system for quality. And this is where there's a partnership between the patients and families, and you can see all the different elements that you need to put in, and there could be more, to get high value co-produced safe care. And this is a learning system for safety that we have to develop. And within that, we have to ensure that the workforce knows all about patient safety. And I believe they have to start it right from the beginning, from medical schools and nursing colleges, so that when they come out of their training, safety is part of what they do. And here's a curriculum, and you can look at the reference that came from Europe on how to teach people, and medical students mainly, about psychological safety and what the things that you have to have in it. And you can go to the reference by Carrillo. And I wrote an editorial on this paper, and I said there are 4 things you have to do. You have to make it part of the genome by having continual learning. You have to learn all the time about safety. You have to have skills that are beyond the medical skills or the nursing skills, but competence in psychological safety so you can speak up. It must be part of the culture of the organization, and that will create it into the genome. That means people do safety as part of what they do. So that is culture, education, and now we get to the viola, which says you need to ensure the well-being for safety. Now this is very important because the studies from the National Academy and Pascal Carrion led on this, it shows that you can either have burnout or professional well-being, and this is all based on human factors, on the environments, on the systems, and most people will experience burnout in their careers. And in fact, burnout is very high in most countries, and after COVID was even higher. And this is really because we have had industrialization of healthcare, in which people are disconnected from the work that they do. And we need kind care to ensure we do not have burnout. Because what happens if you have industrialization of healthcare, in which you don't see what we say is the finished product? You only see part of what the patient has, because you go to all different aspects. It's been very successful in doing this. The cardiologist sees a heart problem, the gastroenterologist the gastric problem, etc. But what it does do means that you don't see the finished product. So you get powerlessness. People have lack of power, lack of meaning, estrangement and isolation, and then they lose their norms. And when you have burnout, what happens is that you get higher risk of patient safety events, almost 2 to 3 times. So this is very important. And of course, if you are a second victim, you have a higher issue as well. And here is from the European course on second victims. You can go to the website, and this is something that's very useful. It's in all different languages. You can see it's in Spanish and Portuguese. So for Latin America, it's very easy to access. And I really encourage you to have training in second victim support, because well-being. So to revise, first you need a good culture. Second, you have to educate for safety. Thirdly, you have to look after your staff. That is so important. And now we can get to the safety theory and methods, because the cellos, number 1, is going to talk about measurement and designing for safety. So what we have to do is make safety our business while we care for people. I'm not calling them patients, because safety is more about having a relationship between the doctor and the patient and making sure they're being safe. So let's just look what the measurement is. I'm not going to go through measurements in detail, but I'm just saying we have to measure for safety. But in the OECD countries, these are the number of the measures that all OECD countries more or less keep, some more and some less. And at the Imperial College, in 2023, at the end of 2023, so not that long ago, they took all these measures and came up with 4 global measures: maternal mortality, treatable mortality, adverse effects of medical treatment, and neonatal disorders. And then they ranked all the OECD countries. And there are a number of OECD countries in Latin America. And these are the rankings. And as you can see, unfortunately, Latin America and the USA are at the bottom, except for Chile, which is higher up than all the other countries. And of course, what we want to do is move everyone up. Everyone up. I have marked here so you can see Mexico, Colombia, and Costa Rica. It might have been an extra number there for the United States should be a little higher. Sorry about that. Anyway, so these are the problems. So you really have to make a big difference in getting this sorted. So here on implementation is the big issue. How do we get people to implement? So you have to identify what works. You need to have research to find out what works well. You have to develop the generalized knowledge. You have to apply the knowledge. And finally, you have to have learning. So implementation is just as important as knowing what to do. You have to know how to implement. And this has been a missing piece in our way we look at patient safety. And then we have these implementation frameworks. I've taken these from the textbook of quality improvement, the handbook of quality improvement. And here you have the intervention, and we know a lot of things that work. We have to contextualize them. We have to look at the processes, and then we have to put them in, look at where they fit in with the policy and resources, the culture of the organization, the networks, and the beliefs and attitudes. This is the culture. So it's so important that we do this. And implementation science coming together with improvement science and patient safety science will make a big difference in getting things done. So I like this diagram we put together, which here you see the improvement science, you see all the methodologies, you see the implementation science, and then you see the patient safety science. But the key thing is that the variability that was completed on one day, the next day can cause the harm. I like this from Eric Holnagel, who's the brains behind safety too. And I think it's important that we keep this in mind, that people go to work to do a good job, and doing patient safety in a way that it's everyone doing bad things is not the way to go. We need to recognize that the problem is not that people go to do harm. It's problems that something happens. We need to learn from what we do not that well, and this is from the UK, from England. They have a special body to investigate in a non-blame environment what went wrong so we could learn. We need to find out what is going on, and this is the latest London protocol from Charles Vincent, including patients, including in-depth analyses, looking at good care as well as at problems, observing how people work. We need to learn from what we do not that well, but we also need to build resilience and learn from what we do not well. Because as Holnagel said, what you do one day may have good care, and you do the same thing the next day and gets to harm. So we really need to understand how we can make safety is what we do every day. So to do that, we need to design and translate theory into action. This is a SAFE program I run, in which you have understanding risk proactively, building reliable processes, introducing human factors and situation awareness into day-to-day work, and enhancing resilience or safety too. And this is about reclaiming the systems approach to pediatric safety when I was writing this paper, but to safety, where we look through safety through the system eyes. And so let me tell you a bit about our program. We've had it in 50 hospitals across England, 100 teams across Ireland, and teams in Sudan, Mozambique, Australia, and Argentina. So we can really show that if you make people aware in a day-to-day work to be safe all the time and constantly thinking about safety, it can make a difference. The evidence has been published for if you want to find it, but it's really about applying safety theory on a day-to-day basis. It's in what we call the huddle, but this is just the tool we use to identify where problems may arise, and this is the identification of children who may or patients who may deteriorate in their number of risk factors. They come to the huddle to discuss them, and they mitigate and escalate. And that's basically what we do. It could be for falls, it could be for medication harm, you could name whatever harm you want to do, but people are now talking about safety every day. And what they ask 2 or 3 times a day are 6 questions. What do we do well? That's learning from excellence. Have we harmed anyone in the last shift? And they use 5 whys, root cause analysis, to solve it on the ground, in real time. They ask if their care is reliable. Are they doing what they're supposed to do, what they've agreed to do? Using care bundles. They ask if we're safe now, using the SEEPS model to look through a human factors lens, whether they are delivering safe care now, and they ask will they be safe in the future with situation awareness. Who may deteriorate, who may fall, who's at risk of medication harm, for example, and most importantly, they're asking, are we learning? And that's so important. Now look at aiming for reliability. This is where they are preoccupied with failure. They're sensitive to operations. They're not reluctant to ask the questions, but they're listening to the front line. This is a high reliability. They're ensuring the reliability by using bundles, and here are a number of the bundles they use. This is for the ICU. They're integrating human factors into daily work using the SEEPS model, developing proactive, productive teams. Sometimes they may train in team steps as well. And they're looking at their data, and they're really studying this all the time. Are we safe now? Who are the people? Do we know our tasks? Do we have the right tools? How are we organized? And what's our environment like? They're asking this on a daily basis. And then they're predicting in the future. This is using a trigger tool, not a trigger tool, but a track and trigger early warning score to see whether or not it is rising or not, whether the vital signs are rising. And there are a number of things you can see on the red which are very important for any patient. This is ready for deterioration, but we could adjust this for any of the issues. And then the question is, are they learning? And then we have safe telehealth. And this is coming right now. We need to think about what's required, how we can educate the clinicians to be safe when they do telehealth. It's a new way of thinking, and we can't expect people just to do it. And you can see some of the things that are required in digital technology, text messaging, video consultation. And to do that, we have to think about the psychological safety, the human factors, the diagnostic accuracy, and communication. And of course, safe artificial intelligence is coming, all about machine learning. How's this going to work? How is it going to help us? And there are a number of areas where we need to look at, particularly diagnostics, deterioration, and prediction of what's going to happen. And of course, how do we engage with patients while we use artificial intelligence? And here are the areas where there has been progress in VTE, and sepsis, and surgical events, particularly in diagnostic and radiology. Artificial intelligence is making a difference, and a number of references that you can look at. Now the last cello number 2. This is where we need to co-produce for safety, and that's co-producing with the people who we care for. The WHO had 2 years ago engaging patients as their theme, and these are the Patient Safety Rights Charter, where you can see what patients really are demanding: safe medical products, safe care, timely appropriate care, and to be heard and to be engaged. I urge you to read this document. And this means we need to co-produce safety with patients and their families. And that means we give up power. And they know better than us what is going on with their loved one. So we need to listen, learn, and work together to produce safety. And empowering really means, and this is from care to shared decision making, it's co-assessing with patients and their families, co-deciding what should happen, co-designing the future, and then co-delivering. The very latest work I'm doing with Paul Batalden says that both sides have to prepare. The patient has to prepare, the professional has to prepare, they're listening to each other, observing, and then they're going to decide how we are going to divide what they need and what they need. And they've all got thoughts. What has to come forward? What content are they going to bring to when they come together to share and plan? And patient safety is part of sharing and planning what's going to work and who has what task in order to provide a service that contains a product that is safe. And finally, let's think on the take-home messages. The take-home message number 1 is that patient safety is about a change in culture. Lesson number 2 is that education from the start is essential, not an option. We have to insert safety into the genome of the HS healthcare workers. We have to design and measure for safety and figure out how to implement, and I've indicated that using implementation science is very important. We have to integrate all the theories and methods to achieve sustainable outcomes. And finally, we have to partnership with the patients, and learning their music is key. I'd like you to reflect on what you have learned today as you listen to the string quartet or quintet end my session. Thank you very much, and I hope you've enjoyed this talk.